Hello and welcome back to The Halfway Point. Today we're going to explore an important topic for general practice, infection prevention control, IPC. We're going to look at it not just from a compliance perspective, but in terms of staff confidence and how we can work together, both clinical and non-clinical roles. And I'm really pleased to be joined today by Steph, working with LPM. Steph's been a nurse in the NHS for a number of years, and I'll let her introduce herself properly in a second. And she's come with a wealth of IPC experience. So we've got the operational and the clinical perspective on IPC covered on today's call, which is exactly what we wanted this conversation to all be about. So to get us started then, Steph, do you want to give us a little introduction to yourself and your role within the NHS and IPC over the years?
Yeah, sure. Okay, so hi Ben, and hello everybody. I'm Steph Bouckley. I've been a nurse for 40 years, just over, and I've been in general practice for just about 20 years now. And for the last sort of 5 or 6 years, I had a role as a lead nurse and IPC lead, and which was thrust upon me somewhat. So that made me think about it in terms of how we can do it better. And then in the last kind of 3 years, I've been doing some national training for IPC. So it's something that I find it's really important. I've got a background in the operating theatre as well. So that's kind of the whole purpose of being there is IPC, isn't it? So yeah, so that's me really.
So thank you, Steph, and welcome as well. So from the clinical perspective then, you talked about how you kind of fell into it, but what does your role almost on a day-to-day side of things sit with IPC? How does it structure in from the nursing point of view, the nursing side?
Okay, so as all clinical people will know, IPC, or infection control, to give it its basic everyday name, it kind of underpins everything that we do. And so when we're training, we're taught about infection control, and we're taught about, so at the point of delivery to the patient of a procedure, hand washing, creating a sterile field, opening sterile packs, etc. That kind of thing is kind of second nature to us, and it underpins everything that we do and runs through our practice, kind of like a blood supply, really. But when it comes to IPC as a whole, in an environment like in general practice, what it means is it really comes from the sort of Health and Social Care Act. The whole thing comes from there to start with, and it's about providing a safe and clean, welcoming environment for the patients. And IPC, it kind of falls into that safe category. So it's not just about managing our infection control at the clinical point of meeting the patient, to do that dressing or to do that blood test. It's also about making sure the environment that they come into is well supplied, with hand washing facilities and all that goes with it, and that it's clean and nice, and so that people don't think they're coming into an area that's, a bit not very nice. So it's actually a real team effort to create that, because in general practice, we're open, we're open door to the public all the time, aren't we? So yeah. Our infection control needs vary from, say, the waiting room and reception into the clinical room, into the consulting room, and the bar risers. Whereas if you're in an operating theatre, the IPC level is at high level all the time, in every part of that department. So I think that's kind of where it sits in terms of how we hope to manage it from a clinical and then also a managerial point of view.
Yeah, and I didn't fully appreciate till kind of sitting in on the training that you and Tracy provide, how much the managerial side sits in that conversation. You've talked about there from the nursing and the clinical side, but it almost creates a culture, doesn't it? So when you've got the management of the practice involved just as much as an IPC lead, which whilst not exclusively tends to fall within the nursing team, doesn't it? I think from experience.
It does tend to.
Yeah, so but then once those two kind of roles combine, then it creates, I think, a bit of a culture in a practice. So do you think there is a risk that practices see IPC as a tick box exercise rather than something embedding in that culture? What do you think?
I think it varies, and I've been to lots of different practices with my auditing role, and what I find is often the case, but not always, is that an IPC lead is often the lead nurse, so there's usually a person who's already got quite a huge amount of kind of responsibility. And what I often find is that, sometimes by practice management and partners, it is seen as a little bit of a tick box thing, and I don't think they always, general practice is extremely busy, isn't it? It's not meant as a criticism, but I think sometimes it's incumbent on us to try and work together. It works better if we work together because the IPC lead and the clinical team need the support of their practice managers and partners to be able to, one, fulfill all the training that's necessary, and then two, to make sure that they have time to carry out the audits, to carry out the staff training that needs to be done, to make sure that there's opportunities to discuss things as well, because things change, guidance changes, things change all the time. So if there's a practice where the manager or the management team, if you like, the senior leadership, are not buying into that makes it really hard for the IPC lead and their team, if you like, to execute all the work that's required. And there is a lot of work. It's always been my view that we're all there as part of one team, aren't we? We're all there to serve the patients. So really, the clinical side cannot exist without the managerial side, and vice versa. So IPC is another area that we need to work in together, definitely, yeah.
And I think the same is true from, I said, the non-clinical side is, we need the clinical input, and the input that the nursing team and the IPC team bring just as much as well. So I think that's an echoed statement there. And one of the things I was thinking about as we started talking earlier on there was, we look at IPC now in a lot of different ways, especially since COVID. There seems to be a bit more public awareness around IPC and hand washing, especially in the mask wearing and all that. Cast your mind back without having too many worrisome memories. But, and then you tend to think of we talk about modern general practice, neighbourhoods developing lately, the big shiny buildings in the middle of the towns or wherever it may be. But there's still a lot of premises that are very, very old, and that's being kind to some premises. So there is still a place, obviously, for IPC. We're operating procedures, but is there almost a fear of, because the building's so old, therefore we're going to fail from an IPC point of view? What's kind of been your experience, especially in some of the older buildings that come across?
Yeah, you're absolutely right, Ben. And you're quite right as well to point out that since the pandemic, the profile of IPC in general practice and all over the NHS, but particularly in general practice, has really risen. Because general practice became the hot sites, didn't they? And we were managing all the patient care. And I think, when we talk about, and before that, really, it really was genuinely a bit of a tick box exercise. And I think there was just an assumption that because clinical staff are working to those rules, we don't really need to worry about it. But actually now the expectations on us are much higher. And I think for a team to be able to work together in creating that safe environment for patients, and it's not just about clinical input at the patient side, it's around isolating patients with contagious diseases. We're much more aware of that now. That's always been a thing, of course it has, and we've always had notifiable disease. But from a nurse's point of view, in the past, it was always very much something that the GP dealt with. Now we all need to understand it, because obviously our reception teams are triaging, at quite a high level, really. And they need to be able to understand that. So it is about spreading, and because IPC is something that it varies in importance in general practice, because it's really important in that it's something we need to do and we are required to do. CPC and guidance and governance requires that we do it. But it's not as high on the agenda on a day-to-day basis as clinical practice, obviously, managerial practice. So that's where we were. And I think the whole thing has really sort of exploded, you're right, around having PPE available and things like that, not just for us, but for patients as well. And when that's appropriate, and making sure that we're keeping up with changes of guidance and changes of requirements for staff immunisations and that kind of thing. It's really important. I've worked in old buildings and new buildings, and you're absolutely right. And I think the challenges for older buildings is phenomenal, the challenge, because in some buildings I've worked in, the integrity of the building is falling apart, basically. So you've got plastic coming off walls, it's damp in certain rooms, in cupboards under sinks, it's damp, you can't really keep clinical stock in there. So therefore your storage is limited and things become cluttered, which doesn't help with managing to keep the place clean. I think if somebody's working in old premises and they feel very much that their IPC is not where it should be, what's really important from a compliance point of view is to make sure that all the areas that you feel are not quite where they should be just need to be really identified, and there needs to be a plan in place to execute that. And I think so having that really sort of dynamic action plan in place and as an ongoing working document is really important. Because, something like, replastering a room and redecorating is way beyond the authority of the IPC lead, who is usually a member of nursing staff. So unless that person is a partner, they don't have that authority. But what their responsibilities is to identify it, have those conversations, put it on the action plan, and maybe give it a time scale. We're hoping to do this by this time, funding accepted. If it's something around staff immunisation, for instance, again, it's not so much the old building thing, but that definitely takes a joint approach, because that's the practice manager's responsibility.
Yeah.
So where all buildings are concerned, it is difficult. Yeah, I've worked in some places that are, questionable in terms of where they're up to. But,
Right.
people are doing their best. Yeah.
Yes,
and I've also
yes.
worked in, NHS managed buildings, as you quite rightly say, these lovely new shiny kind of health centres. That's great, because the NHS takes responsibility for the cleaning.
Mm.
The cleaning is a big problem. And when you've got practices employing cleaners, whether it's from a contractor or their own, in an old building, it's very difficult for them to keep the standard high, because it's dusty and old and damp and mouldy sometimes. So, yeah, it's very, very tricky, isn't it? But I think that dynamic ongoing working document action plan is a really, really good thing to have, and make sure it's up to date, and then it's evidence that one is doing one's best. If CQC do walk through the door tomorrow, or worse still, if a patient makes a complaint, which they do sometimes, they might say, "Oh, we're right filthy in that room," you know what I mean? Then you've got your evidence that you're saying, "Yeah, we know that, we're aware, but this plan in place."
Following the success of LPM's very first New to Practice Manager conference, we are bringing them back with dates right across the country. This year, we're heading to Hull, Salisbury, Newcastle and Preston. And the best part, it is completely free to attend. If you're new to the practice manager role and feeling like everyone else has the manual except you are not alone. These conferences are relaxed, practical and honest. Real conversations, useful learning and tools you can take straight back to your practice. You'll also meet trusted industry partners, leaders in their own field who are there to support you and help you grow with confidence. You will leave clearer, better connected and ready to lead. Head to locumpm.co.uk to book your free place and follow us on LinkedIn and Facebook to stay up to date. We would love to see you there. I like what you said about having the action plan, but actually then doing it, so it's not just a shiny bit of paper in a cupboard that will never get looked at unless CQC come. You've got to then follow through with it. And I think that's where you talk about working in partnership. I think that's where it comes really well. That's the PM can then go off and start to look at, is this something that we need to do? Can we fund it? Is there funding, or does it need to go for the landlord? Whatever it might be for you and your properties. So, and then working in partnership to kind of get the rooms re-established. And you mentioned cleaning there and cleaners. That's probably one of the number one conversations I see in management come up around IPC and the level of cleaners, whether they're in-house cleaners or they're contracted. There is always, probably every day on the support groups, there is always a comment around cleaning. So are there any kind of hints and tips you picked up on over the years for, if not quick wins, but wins in general with cleaners at all? Well, what do you feel?
I feel that it's important that as an IPC, as an IPC lead, or even anybody in the practice notices things that aren't clean, you've got to sort of document it and report it. That's the first thing. So keeping everybody's eyes open, if you like, around that. If you can have, as IPC lead, I tried to have a sort of slightly more direct relationship with the cleaners, but that doesn't always work because one isn't always there at the time that they're there.
True, very true, yeah.
I think it's also about, I've worked in places where, to be honest, the cleaners weren't contracted for enough time, so the investment wasn't there, so they couldn't do what was required. And then sometimes they're just not very good, and I think we have to, so maybe at practice management level, when we're contracting cleaners, I don't quite know how that all works, but is definitely have a sort of probationary period. I'm sure that's what people do now. Because quite often you've had people who are just there, been there for years. I audited one practice where the cleaning rota that you have, the schedule, if you like, that the cleaners use, it was beautifully displayed as it should be, but it was all in English, and the cleaning operatives, the team were Punjabi. They didn't read it, and that was so they didn't know what they were supposed to be doing. They spoke enough English to be able to chat to you and think, but not enough to be able to read that document and understand what it was they were supposed to be doing. So that could be taken straight back to the practice manager and their manager to have that conversation. Yeah. So there's those practical things to do. I think it's slightly in defence of cleaners, because I think you're right. There is a lot of areas where it's just at a very poor standard. And I think we just have to really, really get on their backs about that. There's nothing else for it. But I also think that as clinical staff, it's incumbent upon us to make sure our rooms, our consulting rooms are tidy and clutter-free, because it's really impossible for people to clean a room properly when it's full of stuff, things, plants, personal items and things like that. It's really not good. And they all gather dust, don't they? And at the end of the day, clear away your clinical equipment, put it away. Make sure it's nice and straight, a straight line, like you would at home. You don't cleaning unless your house is tidy, do you? So I think we definitely have a role to play in that. And of course, it's busy. We're all fully booked all the time. Our practice managers are overwhelmed. We're all working really, really hard. Everybody is. So there's no criticism here around people like being slack around what they're doing. But it's just about thinking about, don't overstock your room if you're clinical. Just have what you need for the day. And then at the end of the day, you're not shoving things on shelves.
True, yeah.
Because you haven't got time to put them away. So there's things that we can do. And when we talk to IPC leads in our teaching sessions, we talk about that, about clutter-free. And also that's a great way of managing your resources, because if you've got loads of excess stock on the shelves, that's all money sat on the shelves, isn't it? That isn't being used. Yeah.
And you often find there where it's in the rooms, that when it then comes to ordering, the person ordering might only be looking at the cupboard. So all of a sudden you're ordering more packs of supplies that actually you've got multiplied in 10, 15 clinical rooms down the corridor,
Absolutely.
So, okay, that's really helpful. And I'm glad you mentioned as well, the cleaning role. Interesting to hear about where they've not had enough hours set aside. It's money's tight. I appreciate that, but we have to have provisions to clean the practices.
Absolutely. Yeah.
And the experience I've seen, especially lately, QC will see through that. They'll start to go, a building this size, a practice this busy, etc. There's a rough formula for working it out, and it's clear sometimes when that's not being met, and that will come back on the practice, not the cleaners.
Absolutely.
Yeah, so I'm glad you mentioned that.
Yeah. And sometimes it's just been left and not addressed. It's not that, the practice has expanded, more rooms are in use, more's going on, and the cleaning sort of contract is still the same as it was 5 years ago, so they can't do it.
Yeah, that's a good point. Where we've expanded as populations in the buildings, and that's a really good observation. So I suppose then, making IPC work in practice then, what do you see as some of the common challenges practices face when trying to maintain strong IPC standards?
Okay, so the first one, as we've already mentioned, is the state of buildings. That's a really big problem.
Yeah.
The second thing is around storage and making sure that the storage is efficient and, really, because that is a good way of keeping it tidy, which makes it easier to keep it all clean. Thirdly, from an IPC point of view, is that the IPC lead has a certain amount of work that has to be done every month to keep up with what's required, including updating and following up their action plan items. And that is very frequently not ring-fenced time. So you'll have a very busy nurse or HCA who's IPC lead, and they often don't have a second person, so they need a second person as well, so it's not all
the deputy.
them.
Yeah.
They need time to talk to the staff so that everybody takes some responsibility, because it is everyone's responsibility.
Mm-hmm.
And then they need to have proper ring-fence time to be able to action that work, because if not, it just doesn't get done, and they're behind, and it causes them stress as well, which isn't good, is it? It's not good for them. Yeah. So those are some of the things. And then and on top of that, to make it super, super efficient and brilliant, is really, really good quality documentation and evidencing. So wherever you see people have been able to change to an electronic way of doing things. So, using QR codes to say, I've cleaned that piece of equipment today, I've checked that fridge today, I've done that data log or whatever. Absolutely brilliant. Some practices are not quite there yet with that, but it's something that I've seen used in practice, and it's something I promote when I'm doing auditing and things. And I think that can really help, and it just streamlines the whole thing. And then the evidence is very easy to access. It's easy for you to see. If you've got a system where all your clinical equipment is QR coded, and you can say, I've cleaned that today, whatever, or whenever it was due, and it's on a platform such as GPT-Net. I know others are available. But that's the one I've been using. Your QR code. But then what it does then is it also will send the IPC lead or the lead nurse or whoever, or the practice manager, it'll send you an email if something isn't done. So you can then you've got that sort of double cross-check thing. So I think that's a really good way. Carrying around great big hefty paper folders is no longer appropriate. Yeah. And especially if you're working on more than one site, it's impossible.
True. Maintain that. And that touches on a subject close to both our hearts, the green practice side of that.
Yeah, definitely.
I hate paper. And what do we do if all these cleaner reports at the end of the month, they just go in another folder and eventually they get shredded. So if we can use the digital systems and the impact.
Yeah.
Yeah, and like you said, it's easier to pick up then. And it's also accountability. So again, not just the cleaners, but fridge checks and stuff like that. Has it been done today? Oh, I think so. No one's logged it. If it's not there, if it's not logged, it's almost like the old clinical record logic. If it's not on the system, it didn't happen. So kind of following on from that then, what are some quick wins, do you think? So, let's try and take something away today. What can a practice do when listening to this and go, right, I'm going to do that this afternoon at my practice? Yeah. What do you think?
I think a quick win would be if somebody could be given, half an hour or something, a couple of hours to have a look at the policy and their last inspection or their last audit. See where they're up to. If they feel that things are behind, that's a good place to start. And also try and arrange a get-together with staff, and I mean all staff, everybody, the whole practice team, including the admin and reception, and say, right, this is who I am. I'm the IPC leader. This is what we need to do. And pick out a couple of things that you're particularly concerned about. So it might be that you've got all the wrong coloured bin bags in the rooms, or it might be that the hand washing audit hasn't been done recently. So you can say, right, that's what I'm going to do first. So the next few days or the next few weeks, I'm going to come and see you all, watch you wash your hands, get everybody involved. I think that's a really quick win because people then start to take ownership and let them help you. If you want to check some rooms, you could say, look, I've got a really busy clinic, and you can talk to the practice manager. Can I, allocate somebody from the admin team just for an hour to go and audit this room for me, just to do the tick box, and then they can give the information back, and it gets them to be part of it and gives them some ownership around it. I think those are quick wins. And get your paperwork in order. If you are using paper checklists, which is lots of people still are, make sure they're scanned in every month so you don't get a great big build-up of checklists on top of the fridge or checklists, hanging on the wall in a plastic folder.
Yeah.
Get them scanned in every month into your central documentation in your system, in your shared drive or OneDrive or wherever you want to keep it, so it's all together.
And I guess it sounds obvious, but actually with the tick sheets as well, are they ticked? Is there anything that's an action, or as a cleaner picked up something that might get then lost in as we're filing all this stuff? So I know it sounds so obvious, but read it when you're filing it or reviewing it on Clarity or Practice Index or whatever other system you're using.
Yeah, absolutely. Yeah.
And you briefly mentioned it there, but I would be, having done the training, and the most feedback I get from those who have done it, all the comments I get is, I didn't understand the cost of bins with the NHS.
Yeah.
So I've got to ask you about bins.
Yeah.
I bet you didn't think we were talking about that when you woke up this morning.
Yeah, no, bins are important. Oh, they're very important. Yeah. I know. Yeah. So the offensive waste stream, which came in kind of about 2.5 years ago, didn't it? Absolutely. And I'm still going to practices where they've got all orange bags in the bins. So the orange bags are for infectious waste only. Yeah. Or yellow and black stripe bags are for your what we now call offensive waste, which is what we used to call all clinical waste. So be discerning with your team. If you don't need an orange bag in every room, don't put an orange bag in every room. Because they cost something like 30% more to get rid of than a yellow and black. And then other things like downgrade your waste. So couch roll from the couch where the patient's laid on it. If you haven't carried out kind of an intimate procedure or something like that, put it in the household waste.
Right.
If the patient's just laid on it to have one stitch out of the tummy, then you don't need to put it in the clinical waste. So chat to your teams, talk about bins, make sure you've got them all labelled and everything. And what I did in my last place was we basically only had 2 orange bin bags in the whole practice because we didn't do a lot of dressings and infected things.
Right.
So we had 2 orange bins, and then we had a little standard operating procedure so that if we did carry out a procedure in our room that we thought might be infected, a patient might be infected, we had a little SOP for wearing PPE and being able to carry that rubbish to the orange bin.
Got you.
And then hand wash. So you can sort it out. Some practices maybe do need an orange bin in every room. It's not for me to dictate that. It's
no.
decide for themselves. But I think you can be discerning and definitely get that message home with your team. It's really important. And things about sharps boxes as well. Orange, purple, yellow, using the correct ones, correct sizes. Don't put a humongous sharps box in a room where nobody ever uses a needle. Just a little one. And make sure they're dated and signed.
Yeah, true. And we can always, I think about when we do our flu clinics and stuff like that, and we utilise rooms that might not be used the rest of the year, we can always adapt them for that clinic. It doesn't mean that it has to be there for the rest of the year.
Absolutely.
We can bring the stuff in the morning and take it away at the end of the day.
Absolutely. Yeah.
So that's a really good point.
If you've used a Sharps box for a flu clinic and it's only half full, put it in another room, use it. Use it till it's at the fill line and then get rid of it, rather than just leave it standing there for a year in a room that isn't going to be used.
Yeah, and it's really eye-opening, because when obviously this stuff is funded locally or even centrally, we don't see these costs, but these are all costs that add back up to the NHS and affect our own budgets, again, locally or nationally. Absolutely. So, they all add up, don't they?
They do.
Significantly with the bins.
Yeah, and it is part of the IPC lead's role is to carry out annual training with the staff about waste management, ops management, the correct colour, and because the boxes cost different things as well. A purple lidded box costs £1,000 a tonne to get rid of, whereas the yellows are, it's virtually nothing in comparison. So it really makes a difference. And also what you're putting in them. So that's part of the IPC training that the IPC lead would do with the staff. So it wouldn't be external training. That would be done internally, annually.
Okay.
Yeah.
And you and Tracy run monthly IPC training sessions with LPM.
Yeah.
So you tell us a little bit about them, how they're structured, how they run as well?
Sure. So what we've taken an integrated approach where we have management and a clinical side to it. So basically what the IPC training session looks like, it's very much around the compliance, the guidance, the legal, the legislation, the practice manager and practice senior leadership team's role, and around the responsibilities they have and what's expected from national guidance, etc. And that part of the session is delivered by Tracy, who's got an extensive experience in general practice management and business management. And then the second part of the session is delivered by myself, and that's about infection prevention control. So what I don't talk about so much is the actual nuts and bolts of, cleaning your trolley and opening your sterile field, okay, and breaking the infection chain, because that is something that we do annually in our mandatory training anyway. And as clinicians, we should know that. But I talk very, very much about how to manage the IPC workload with your clinical staff, with everybody, and how to keep those records, how to keep that action plan, when and how to deliver your training to your staff, the training that you have to do, which is your waste management, hand hygiene, cold chain, sample handling, those kinds of waste, all those kind of things. But how you can fit that in, managing the time that you're given, well, making sure you get that time, that's the first thing. Right. And then how you manage that throughout the year, how you keep records of that, keeping an IPC diary. So I talk very much about managing the workload and making sure you're keeping good records and evidence, because as I said earlier, particularly if you're in an old decrepit building, you don't have any authority. As IPC lead, you can't go and buy a load of new chairs in the waiting room because they don't like.
No, of course.
You can't get the decorator in or the joiner or whoever, but you can have it on the action plan, chat with the senior leadership team and say, I feel this is important now, And then obviously you've got we talk about stewardship around antimicrobials, which is the part that I do.
Of course,
Immunisation and occupational health. So that's how the session runs. And Tracy sends out the slides and a resources pack at the end as well. And we give everybody our email addresses. So if there are questions afterwards, people can come back to us. Yeah. There's lots of time for questions during the session as well, which is really good. But actually, sometimes people think later, I wish I'd asked about that, They don't think, and then so they can email us, and we get emails from people all the time, which is really nice. Yeah, and then on the back of that, of course, we do offer our visits, our audit help.
Yes, of course, yeah, and that's the site visits. And helping practices out. So I think if that sounds useful, we'll include the details in the show notes for this episode as well. Okay. And I think that's a lovely note to end on as well. So thank you, Steph. It's been a really practical and insightful conversation.
I hope so.
And a really good reminder about infection prevention it's not just about the policies and audits. It's the people, the communication, working together.
Yes.
To keep patients and staff safe as well.
Absolutely, staff as well, yeah.
Yeah, absolutely. Thank you. So, Steph, thanks again for joining us today. Thanks, everyone, for listening, and we'll see you next week at the halfway point. Thanks, Steph.
Thanks. Bye.
Thank you for joining us today for another episode of The Halfway Point. We hope today's conversations have given you a fresh inspiration and practical ideas you can take straight back into your practice. You will find all the links and resources we mentioned in the show notes at locumpm.co.uk. The Halfway Point is available on all major podcast platforms, in both audio and video formats, so you can tune in however suits you best. If this episode helped you, we would genuinely love to hear from you. Leave us a review or a comment. Not only does it make our day, it also helps us shape future episodes around what matters most to you. Make sure you follow and subscribe so you do not miss next Wednesday's episode. And if you know a colleague who would benefit from this conversation, please share this episode with them. You can also connect with us on LinkedIn and Facebook by searching for the Locum Practice Manager. We're on YouTube too, where we share practical tips and tutorials for primary care managers. Until next time, keep moving forward, keep improving, and we'll see you again next week at the halfway point.